evidence-based series. Before we begin, we just have a few points of housekeeping. We will be using the chat function for question and answer. The button to access this is at the bottom of your screen. Please send all your questions through the chat box and feel free to introduce yourself. If you're having any technological issues, please send a message through the chat. And this session is being recorded and your attendance is consent to be being recorded. Thank you. So welcome to today's session. Our topic today is pediatric considerations for oxygen and critical care. And as usual, we're happy to have our following panelists, Professor Paula-Ann Benguti, Liberata, Dr. Honorine, Dr. Jackson, and Dr. Francois. And with that, I'll hand it over to Dr. Benguti.
Thank you very much, Alana. Thank you very much, Assist India, for organizing this session. This is the 9th session. We have started since January and we are progressing well. Today we are touching one of the special classes, special range of population, pediatric one. We want to see in what we've discussed in the past about oxygen and oxygenotherapy and critical care. How do we take it in pediatrics? How do we manage pediatric cases? What are the particularities? So that's what we'll discuss today. Next. Let us start with a case. Then we'll put it into perspective, give you an idea, leave you with questions. Then throughout the education, throughout the session, you will find answers to questions related to this case to discuss. So we have a 6-year-old male with no significant past medical history. So wherever you are, you can also be reading it. The baby presents 6 years old, presents to the emergency department with wheezing and increased work of breathing. His symptoms started 12 hours ago. He has been less active for the past 24 hours by his mother's account. His mother also describes 5 days of fever with a maximum temperature of 39.3 degrees Celsius. He had a respiratory viral panel and rapid COVID test 2 days ago, and both were negative. At the time of the respiratory panel and the COVID test 2 days ago, he had no respiratory symptoms. However, his mother does report that his eyes were red and he has redness and swelling of his hands and palms. She also reports that today his eye seems swollen. The patient's aunt lives in the same house and had COVID-19 3 weeks ago, but her only symptom was anosmia. Next. Next, please. So, as antecedent history, the birth history is 32 weeks spontaneous vaginal delivery with severe preeclampsia. 4 weeks in NICU, so you were sick at birth. For feeding and growing. No CPAP, no mechanical ventilation needed. Past medical history, none. Past surgical history, the baby had appendectomy 2 years ago. Social life at home, he lives at home with parent, grandparent, and paternal aunt and uncle, and aunt with recent COVID-19. So vaccination up to date, expect early influenza, decreased clinical access due to pandemic. There is no medication going on, and there is no allergies. So the intended outcome throughout the session will be we have 8 expected outcomes. We want to know how to recognize hypoxemia, how to diagnose it, what is the pathophysiology. That first session will be led by Xavier, who you can see is already present, but might have issues of communication, but will be close to him to back up. Then Liberata will take up the next session to give us goals of pulse oximeter, then oxygen supply option, oxygen delivery devices. Then we will end with oxygenotherapy and critical care, how to prescribe appropriately oxygen to the baby. So from this, Xavier, the floor is yours. Next session. So Xavier is the one supposed to take us. So before he got a good connection, we've discussed already.
Sorry. Are you hearing me? Are you
ready?
I'm ready. Are you hearing me?
Yes, we can hear you.
Do you hear me?
Yes, please.
Thank you. So when I'm going to discuss about hypoxemia in pediatrics, there are important concepts we already got information and the difference hypoxemia and
hypoxemia and hypoxia. We've discussed in the past that hypoxemia is at the level of the blood.
Yes. Hypoxemia is at the level of the blood, while the hypoxia is at the level of the tissue. So if the hypoxemia is not area detected, it will lead to this hypoxia and the cells will not work properly and may lead to the death.
Next. Next slide.
Yeah, still on the same topic of hypoxemia, we have to know there is oxygen in the bone, there is no oxygen. And we have to, from the air, our room air, we are having
So we have 2 forms of oxygen. Oxygen is in our blood into 2 components. There is part which is dissolved into the blood, and another part which is bound to hemoglobin. So when we measure the saturation, we measure the saturation of oxygen which is bound at hemoglobin. That is done with the pulse oximeter. We put the pulse oximeter. Liberata will take us through the pulse oximeter. And you can also measure the arterial saturation of blood, which is done with you just take a sample of blood, put it in an arterial blood gas machine, and you receive the saturation, the arterial saturation of blood, which most of the time is equivalent to the pulse oximeter. So the pulse oximeter works with the spectrometry, where it's not invasive, it's non-invasive, where the arterial saturation is invasive. So we take a blood sample and take it to the blood machine. So the average of good saturation is between 92 and 97. And so if the lowest is 90 and the highest is 100 saturation, so you can't go beyond 100. There is many factors which can influence this saturation. Next. So clinical signs of hypoxemia are cyanosis, respiratory distress, grunting, or depressed mental status. When you see those signs, there is emergency signs. There is combined with obstruction, respiratory distress. When we talk about respiratory distress, there is many signs going with respiratory distress. It's just a sign expressing that you need more oxygen. Your supply is not related to the demand. The demand is too high, the supply is not enough. So you are suffering, you are striving to get more oxygen, and you end up with signs of the hypoxemia. So, and that will be diagnosed at the end by the pulse oximeter. When you put the pulse oximeter on the patient, you will see the number of your pulse oximeter on the pulse oximeter will be below. And if you do a blood gas machine, you will have a partial pressure of oxygen, which will be below 80 or below 70, and the arterial saturation will be also very, very less. Next. So while detecting, as we are discussing, while detecting the hypoxemia with the pulse oximeter, so you need to have, require a little bit of technology to put on your finger. So it's not fancy. It has been simplified into a small equipment which can be mobile. And I think all of us, we've seen a pulse oximeter, and Liberata will give us a picture. The blood gas machine works is very invasive. So it's invasive because we have to take a blood sample. We have to take a blood from the artery. That blood needs to be kept in a small, with an anticoagulant, heparin, so that it can be examined. So you found the blood gas will give you the pH, it will give you the partial pressure of oxygen and other gases like CO2. So it can be very expensive and uncomfortable because you need to sample. It's also very. Next. So now, what is the pathophysiology? Meaning, what happened when you are what happened when you are in hypoxemia? So, in the past, we've discussed about many different levels of cause of hypoxemia. If we go from the air up to the blood, because hypoxemia is the blood, the consequence of hypoxemia will be into the tissue, because if there is no enough blood into the blood, no enough oxygen into the blood, the cells will suffer. The cells will not receive enough oxygen. Just like, we take an example, the teacher is in the auditorium expecting students for the class, but there is no bus, there is no motorcycle, and students live 10 kilometers away. So if there is no bus, students can't embark in the bus and come to the class. So the people driving the bus will complain about not having customers to give them money. That is hypoxemia. But the end complaint will be to the teacher, who will wait the whole day without students. He can't teach. That is hypoxia. hypoxemia is the driver of the bus will not get money because there is no oxygen on the hemoglobin. There is no student, there is no passenger in the bus. So now what happened? Sometimes it's not from the air. The student didn't get up. The student didn't want to go to class. So it means going into cause of hypoxemia, we start from the air. It can be hypoxic hypoxemia. From the supply of the air, there is no enough FiO2, either because you are in high altitudes or because there is an hypoxic gas or other environment like it is too hot. Many reasons can end up into hypoxemia. And it can be also due to airway obstruction. If you are suddenly obstructed, strangulated, you can't breathe in. Or maybe you have a foreign body in the mouth, you can't breathe in. Or you have just mucus plug into the trachea or into the bronchus, so you can't breathe in. It can be a ventilatory problem. So air can't move from the atmosphere into the alveolar. There is obstruction. That can be another cause. So there is no good air entry. Or it can also be another problem of diffusion. So it means you have good air entry through your mouth, through your nose, through the trachea, through the bronchus, but the alveolar are not, there is no good diffusion between your alveolar and the capillaries for your hemoglobin to be saturated. So that will be another cause of hypoxemia. So, you know, those are the causes. So when we don't have enough oxygen into the blood, then the cells will suffer. That will be the consequences of hypoxemia. Next. So we can have types of hypoxemia, hypoxic hypoxemia. I told you about hypoxemic hypoxia. So we can have for hypoxemia, it can be in high altitude, in hypoventilation, in a problem of diffusion or shunt. So if you remember very well in Gannon, when they're explaining about zone of West, zone 1, zone 2, zone 3, we have some zone which are well ventilated but not perfused, and some zone which are perfused but not ventilated. So that will be that's what we call zone 1 is the zone which is very ventilated but not perfused. And the zone 3 is well perfused and it's not well ventilated. That will cause shunt or dead space, which end up into hypoxemia. About hypoxia, because hypoxemia will also cause hypoxia. We can also have beyond causes of hypoxemia, we can have causes like anemic hypoxia, which is not hypoxemia. You can have good saturation, but when you are in anemia, we have just few molecules of anemia of hemoglobin, which are saturated on oxygen, but the content is not enough to perfuse your cells. And it can be also isotoxic hypoxemia, where the cells are toxic and they can't really drive oxygen to the mitochondrion. Next. So pediatric considerations of hypoxemia, we have can have hypoxemia at higher frequency, where we have respiratory distress. Causes are pneumonia, transient tachypnea, and whatever. We can have prone to condition of the baby, prone to apnea, like prematurity, sepsis, and seizures. We can have acute lower respiratory tract infection and other illness like asthma, meningitis, sepsis. You know, all those are due to either it is low FiO2 or problem of ventilation or problem of what we call hypoxia. It means the alveolar partial pressure of oxygen is reduced due to either secretions or fluid overload, or if we have a lot of humidity in the alveolus, or it can also be a problem of diffusion. So, or general condition like sepsis, meningitis, or trauma. Next. How to treat hypoxemia? This question will be digging deeply. It will be deeply in the third chapter at the end. But we need to depend on the indication and the source on the device. So for this one to be well understood, I give the floor to Liberata, and Jackson will come to put it to conclude on the treatment of hypoxemia. Thank you very much. Liberata, the floor is yours. Next slide.
Thank you so much, Prof. Before treating it, we have to understand where our goals for different clients that we'll be having in front of us. And the first one is premature babies. Premature babies, their target of SpO2 will not be the same as old children. If we are having a premature child in front of us, we will target the SpO2, which is between 82% and 95%. And when we have those premature babies or those babies who are having raw weight at birth, we have to consider or to have in our mind that the oxygen we are giving them at birth may result to some complication like retinopathy of prematurity. So if we have this in our mind that this can happen in the future, we have to give like an appointment to the family to come back between 4 to 6 weeks and check if the child is not have complications from the oxygen that he or she received at birth. So this screening should be done between 4 to 6 weeks for all babies who were underweight and received oxygen, and for those who were premature. And we have to know that as the smaller the baby is, the chance of having this retinopathy is also high. Next slide, please. So to other children now, depends on where children will be coming, as Prof was explaining. If the child is living in high altitude, the oxygen target which is needed differs from those who are living in low altitude. For those who are living high altitude, it is defined above 500 meters above the sea level. So those ones, even their target for SpO2, even it goes till 87%. And those who are living in low altitude, when the oxygen saturation goes below 90%, the oxygen therapy should be considered. But those living in high altitude, we go below and reach to 87% before deciding on giving them oxygen, remembering that for the need of oxygen for those living in high altitude differs from the need of oxygen for those who are living in low altitude. Next. So, considering our settings, sometimes you may have a child in front of you, but you don't have a pulse oximeter, as Prof was saying, that the equipment which should guide us to decide if someone is hypoxemic or not. So if we don't have the pulse oximeter, we can be guided by clinical signs and decide on giving oxygen supplement for our clients instead of exposing him or her for further complications due to hypoxia. So if a patient is having central cyanosis, or if he's or she's presenting nasopharynx, the nostrils are like they are dancing, granting with every breath, the breath is noisy, it's rowdy, you have to consider that this patient, even if I don't have a pulse oximeter, but he's facing a low level of oxygen. If that child is not able to drink or to breastfeed, if the child is very weak, drowsy, you see, And if the respiratory rate you count and find them be above 70 cycles per minute, even if you don't have a pulse oximeter, but meanwhile you are having those clinical signs in front of you, you have to decide and supplement oxygen for this particular patient. Next slide. So now oxygen devices, we've talked about them before. Let's review them, revise them for this particular population who is a child. There are two categories. Some are non-invasive oxygen delivery and the others are semi-invasive, means we need to introduce it within the nostril to give oxygen to our patient. So those non-invasive, there is no need of inserting something in the nose. We can say like a face mask, they are head box, which are rare in our context. We don't have them here in our country. And those ones, they give high flow of oxygen. And you remember, if the high flow of oxygen is given without humidification, you know the complications which will result, like the mucus will be very dry, and sometimes it may lead to obstruction due to that dryness. They are also expensive because of that high flow of oxygen they are providing. For semi-invasives, they are the ones we are much familiar with. Those are the nasal plungs that we give, and they are good because they require low flow of oxygen, and they are not expensive compared to non-invasives one, and they give some kind of PEEP, which improve oxygenation of a child. So if you go to how much should we give for our child? If we have a neonate in front of us, we should give between 0.5 to 1 liter per minute using the nasal plungs. If is the infant, means from 0 to 1 year, you give 1 to 2 liters per minute. If it is an old child, you can go to 4 liters per minute for older children. Next slide, please. Nasopharyngeal catheter, it's just practical consideration that we have to have in our mind. When we are inserting it, we go 1 centimeter through the nostril, and we have to secure it with a tape. And the maximum flow rate, which should be set for 0.5, we've talked about this, for neonates, and 1 liter per minute. So we have to have in our mind still, because we are like giving an air through the nose of a child, he might end up with developing gastric distension. This is why, to prevent this gastric distension, when we are using a nasopharyngeal, we also insert a nasogastric tube for the decompression, so that if there is a risk of causing gastric distension, there is also a chance of bringing back that air through the nasogastric tube. Next. Next slide, please. So these are still the practical considerations. The flow rate, we've talked about it. It's just a matter of mastering them well. When we are having neonates in front of us, how much are we giving? When we are having infants, how much are we giving? When we are having older kids, how much are we giving? The plungs should be secured with a piece of tape, and this should be attached on the cheeks of the child. So as we were saying, remember that higher flow rates without effective humidification, they will lead to dry of nasomucosa, which will end up by bleeding or airway obstruction as complication of those oxygen delivery devices. Next slide. So there might be some complications from those delivery devices for kids. A child may have hypercapnia, or these devices can be dislodged easily. If we are saying that the nasal plungs or those nasopharyngeal should be attached on the the cheeks with a tape. If you forget that, there is a high chance of dislodgement, and the child will tend to be hypoxemic, and yet you thought that the patient is receiving the oxygen supplement. Airway obstruction will result from the high flow rate of oxygen, which is not humidified. And the gastric distension, we've talked about that one, and we know now how we can prevent it by inserting a nasogastric tube together with that nasopharyngeal tube. Next slide. So now we have oxygen supply options. This is the like a revision from what we've seen earlier in previous sessions, where we had those cylinders. We have an oxygen concentrator. You remember, the oxygen that we are giving in hospitals comes from concentrating what we have in our atmosphere by concentrating it and bringing it from 21% to 100% so that we can give it to our patients. So this is the cylinder that we are familiar with, and the oxygen concentrator, which will help us to concentrate the atmospheric oxygen using, you remember, the technology which is called PSA, so that it can concentrate our oxygen and give us the one of 100% from the 21% from the atmosphere. The next slide. We have oxygen plant and the concentrator again. All of them, they are source of oxygens. It's just to know where we get the oxygen that we are using for our patient. I think the next slide is for Dr. Jackson. It's over to you, Dr. Jackson.
Thank you so much. Thank you for having me. Thank you, the audience, for just having me coming in. And we are going to discuss how we can treat those patients who need oxygen. So Prof discussed about students coming in and then the lecturer giving lessons, and there's a way to transmit information, and then I'm now going to feed on the students coming in. So we've diagnosed hypoxemia in children, and then after diagnosing, we've found ways to give oxygen to them. Now we are going to discuss the way we can, on which parameters can guide us to give oxygen. So how we can appropriately prescribe oxygen therapy will be guided to pediatric patients, have guidelines, and how appropriate therapy options are being chosen, among others, will be our guiding presentation. Next slide, please. So there are goals in case you need to give oxygen to pediatric patients. Of course, we have all the types of respiratory failure. You may have type 1, which is hypoxic hypoxemia. In this way, you need to give oxygen. So you relieve hypoxemia and maintain adequate tissue oxygenation, and then you type the vital organs. And then you refer to what we call SpO2 and FiO2 monitoring on the clinical signs that you have. Again, we may give oxygen referring to type 2 respiratory failure, where you need just to help the patient have adequate energy from oxygenation from the tissues, and then have adequate energy to prevent excessive CO2 accumulation, and then on appropriate flow rate and delivery devices accordingly. And then after treating all the two types of respiratory failure, you may just go now reduce the work of breathing, because the cells have been just hunting for oxygen. Now the cells and the whole pipe is happy, and then now you reduce the work of breathing. So Humidifying that we use during oxygenation helps us to adequately clear the secretion and limit the adverse effects or events from hypothermia and insensible water loss by use of optimal humidifications. And then we can target maintaining efficient and economical use of oxygen by escalating or de-escalating the flow rates and FiO2 that we are providing to our patients. So the targets, there are selected cases or patient groups that we can use to target which FiO2, which fraction of inspired oxygen we can provide to patients. 94 to 98% to any patient with cyanotic congenital heart disease or chronic lung diseases. And then you may target an FiO2, an SpO2 of more than 70% to every cardiac patient who underwent cardiac surgery. So in case you have congenital heart diseases, more than 60% to any patient who has unimpaired congenital cyanotic heart diseases, 91 to 95% for premature or term neonates, and then bronchiolitis has got its consideration, as you know well, when it is more than more or equal to 90% on SpO2. When you target this, and then when you go beyond those values we've provided, you need to de-escalate your FiO2 that you are providing. Next slide. Next slide, please. Great. Now, how to appropriately prescribe oxygen? Remember, there's just the target that we've provided, we've discussed. Now, there are some other clinical or paraclinical conditions or the clinical parameters that will give you a hint on how to provide oxygen or prescribe it. When it is a transient or self-correcting desaturation without any physiological correlates, any derangement to the physiological changes or the vital signs of the patient, exclusively no need of oxygen to these patients. So observe them, monitor their saturations, position them, and then we shall see how non-pharmacological measures can help just reduce the oxygen that you're providing to patients. And threshold for oxygen therapy can vary with children general tests, status, and point of status that the patient has. And then in that way, child with normal SpO2 or increased work of breathing, they are saturating so well, but they've got an increased work of breathing. Do we really need to give oxygen? It's upon evaluation. You have an ABG with you, and then you do an ABG, you see that your patient is so well. When you are in an ideal world, when you do ABGs and then you see that the partial pressure of oxygen is just intact, no need of oxygen. So treatment of documented hypoxemia or hypoxia will be determined by SpO2 in remote area or inadequate blood oxygen tensions that you shall see with partial pressure of oxygen, as I said. Treat an acute or emergency situation where hypoxemia or hypoxia is suspected. Or if the child is in respiratory distress, please treat with oxygen, give oxygen to such a patient. Short-term therapy, post-anesthesia, post-surgery, those patients may have surgeries involving the thorax, surgeries involving the chest, upper abdomen. Those patients may be sprinting up, and then due to pain, they are not getting too much PEEP to allow their lungs extension, and alveoli and getting collapsing. So you need to provide some oxygen. First, for just stress of surgery, high metabolic demands, so give oxygen. Any patient with sepsis or nervous injury, central nervous system, in the traumatic brain injury, we need extra oxygen. Serial evaluation of patient who consistently need further oxygen therapy will be needed. So don't leave a patient on oxygen just for your safety. No, serial evaluation is needed. Next slide, please. So this is a flow chart that was that we got from WFSH. They recommend the flow chart that will help you to prescribe oxygen according to what the patient is presenting with, clinical parameters and paraclinical parameters, what the nurses are showing you. So oxygen saturation less than 92 at rest. Assess your patient for changes in skin color, level of consciousness, rate and quality of respiration. Assess if your equipment is appropriate for the size, it is really working. And then nurse intervention will be there just to monitor SpO2 throughout, sit the patient up, encourage deep breathing, coughing out. If required suction or cavity or tracheostomy tubes, just suctioning to remove all these secretions just for mechanical obstruction. And then from that point, you discuss if there are any severe hypoxia, no hypoxia, or mild to moderate hypoxia, and their treatment is just different. Severe hypoxia, when your SpO2 is below 88 or equal to 88, so you need to apply oxygen via nasal planks at 6 liters per minute. And then, so you need to collaborate with the nurses, and then assess after 5 minutes, reassess if the SpO2 equal to or about 92%. So this patient is leaving this category of severe hypoxemia to not hypoxemia, because the patient that you are assessing now doesn't have any hypoxia. So put on face mask if the patient is below 92% again, or simple face mask at 10 liters per minute. This is what we call escalation. So if this is not providing just enough oxygenation above 92%, you need to go to other respiratory therapy, where respiratory therapists will arrive, assess patient where they have the respiratory therapist and apply high flow oxygen masks, like non-rebreather face mask can help to this point. And then your patient will not be hypoxemic if their SpO2 is more than 92% or above. So to this point, you need to continue with the current oxygen therapy in case, or you need to assess every 5 minutes if your patient still have this saturation above 92%. And then you start now decreasing oxygen flow gradually, reassess SpO2 at each increment or decrement in case, and then consult respiratory therapists prior to titrating therapy where they do have. In our settings, we do not have respiratory therapists. So in that way, you need to assess or communicate with the anesthesia providers. If I guess we have all the anesthetists all over the hospitals in our country. And then you may just need to assess this and then communicate to the doctors who is on duty or just on call. Then mild to moderate hypoxemia, it's in case you have saturation between 89 to 91 in the kids. So put on nasal planks at 2 liters per minute flow, collaborate with the respiratory therapist or the nurse around the floor nurse, assess every 5 minutes. So after 5 minutes, if you assess and your patient has SpO2 which is equal to 9 or above 92, again, you may just conclude that your patient is no longer hypoxemic. If the patient is hypoxemic, again, you increase oxygen flow by 2 liters increment until SpO2 is stabilized above 92%. You reach 6 liters via nasal planks. If your nasal planks are no longer increasing your SpO2, you may go to a face mask or simple face mask. And then that's the way. This flow chart helps to assess and just decision making in case you are alone or you have someone around you to help you, and it helps a lot. Next slide, please. So there are interventions to treat and prevent hypoxemia. You are in a remote area like my hospital, far west of Rwanda, where you will not have oxygen in internal medicine ward. So you need to raise the head of your bed. This helps to effectively promote breathing, descend diaphragm, make the diaphragm down, maximize inhalation, and decreases the work of breathing. So if your patient is really communicating, you may just exercise them to take a deep breath and just coughing technique, because they clear their airway while maintaining their oxygen levels. I can share the experience I got. We had a patient who got hypoxic cardiac arrest during CT scan. So we had oxygen flow, but they erroneously connected not so well, and the patient got cardiac arrest. So we did CPR, and the patient returned back quickly. So what we did was just to tell the patient to have a deep breath despite the high flow oxygen, because the patient was COVID-19 positive. And then the transport was just so super, because they took a patient to the COVID center, and they arrived there so well. And the patient, when they were doing this technique, she was saturating at around 80, but when no techniques of coughing or deep breath, she was desaturating in 50%. So oxygen therapy and equipment. So you need to supplement oxygen as discussed by Liberata. So you assess need for airway patency in case it's just in case the patient have bronchiolitis, and for anybody asthma. So you need to use bronchodilators, mucolytics, steroids, or suctioning in case you need to clear their airways. Their time pain management can help you, and then treat pain. So pain increases the need for oxygen supply. So please provide oxygen. Next slide, please. So you apply and titrate oxygen therapy according to hospital protocols, but those protocols are adapted to safety of the patient and safety of the hospital and the availability of the oxygen source that you have. You always need to assess for underlying respiratory disease, because they can just tell the way you will be providing oxygen. Patients with COPD are at increased risk for acute hypoventilation and carbon dioxide retention in case you give too much oxygen. Type of respiratory failure that will guide you to treat this hypoxemia. And then regardless of the underlying condition, your first priority is prevent and treat hypoxia. Give oxygen. At any expense, at any way, give oxygen. Check all equipments for safety and function at least once per shift. Avoid interruption of oxygen therapy during patient transport. When patient has a tracheostomy or high flow nasal cannula, oxygen system is being transported out of your care, contact respiratory therapist. In our setting, of course, I will need like someone who is experienced in oxygen therapy, like anesthetist who are currently being used in case you have critical patients. That's it for just applying. Next slide will be, if I do the course so well, be back to Professor Banguti.
Dr. Jackson, there was a question in the chat. Trifoni asked, how does pain increase the need for oxygen?
So thanks for the question, and thanks, Anna, for reminding me for just that question. pain itself will prevent chest extension, and then the farmost alveoli will get collapsing. Second, pain causes increases the need for oxygen for oxygen consumption. It's a hypermetabolic state. So this will consume the rest oxygen that you've been using, and then collapsing alveoli due to pain that prevents extension of your chest will also lead to hypoxemia. So you need to treat pain for chest expansion and then provide extra oxygen because pain is hypermetabolic state. Thanks. Welcome, Prof. The floor is yours.
Trifoni, thanks very much, Jackson, for the answers. So this is, I think it's not the first time this question is back. Pain can be nociceptive pain, it can be neurogenic pain, it can be cancer pain. All those different type of pain will cause a stress status. And when you are in stress status, you end up with stress hormones released, which will cause catabolism. So they will break out some tissues, some cells, and will enter into a hypermetabolic status. And when there is metabolism, there is always need for consumption of a lot of oxygen due to the hypermetabolic status. So you need a lot of oxygen in that status. So at that time, if you need a lot of oxygen, so you need to either to have more FiO2, or you need to increase the work of breathing by using your muscles. So imagine if it is really headache, or if it is chest pain, the brain, the chest, those are part of the body which participate into the breath of work. So if they are also impaired, like the chest, you can't expand your chest, you can't expand your muscles to allow enough oxygen for a good to increase your supply. If it is the headache, so your brain needs to work to increase the cerebral metabolic rate of oxygen to produce again more work of breathing, to support the diaphragm, to support other muscles for breathing, so that you can supplement enough oxygen. So if you can't make it, then you just fail and get into respiratory distress. I don't know if I answered your question.
Thank you, Prof. I think we had another slide for complication of oxygen therapy, which I think is very common to the audience. You know, when you are attending CO2, it leads to narcosis. Then chronic respiratory obstructive or respiratory insufficiency will lead to hypercapnia. This hypercapnia may lead to narcosis or just a kind of sleepiness due to acidosis into the brain. And then remember, monitoring of SpO2 just central oxygen informs the status of oxygenation only, but doesn't give you a hint on what is going on. So you need to go ahead and look for the causes. As Prof said, pulmonary atelectasis may happen because you're just sprinting due to pain, but also in case you give what 100% oxygen, your alveoli will be having like the reserve oxygen in there. When you just try to expand, we have what we call diffusional atelectasis, and then at the end of the day, your alveoli will get atelectatic. You may have pulmonary oxygen toxicity with what we call free radicals from oxygen that we are giving. When you give more than 60% of oxygen as a fraction of inspired oxygen, this can lead to damage due to free radicals. premature babies are at risk in case you're giving too much oxygen because their retina will get damaged. So you may have substandard pain due to characterized by difficulty in breathing and pain within neonates due to oxygen that you've been giving, and then they get just all these deformities due to that. I think the next slide will be upon Professor Wanguti, who will be responding to the questions. Prof, the floor is yours.
Oh, thank you. Thank you very much. So before we enter into the questions, I would like to trigger the audience if there is any pending question. Is there any pending question or any other concept you would like us to explain, to go through and develop more? Please feel free either to unmute yourself and speak out, or just to write into the chat. Meanwhile, Liberata is preparing to take us through those questions. Just let us wait and see if there is other questions coming in.
Thanks, Prof. While they are thinking about questions, I wish to remind them there is a good PDF book which is having very detailed information about the today's session. If they go to LRC resources, they are very nice book which can help them to be a reference from now till their working experience, where they will be working.
So let us, next slide. So Liberata will take us through two questions. If there is any other question, please feel free to write into the chat.
I think everyone is reading. We can hear from their responses from those statements, which one is incorrect regarding the oxygen therapy in neonates.
And they can use this score and then just we see who are option 1, option 2, and option 3.
Any response? The first option is saying that all infants below 32 weeks gestation or who are weighing below 1,250 grams who have received oxygen therapy at birth should be screened for retinopathy of prematurity at 4 to 6 weeks. Is it true or false? Is it true or false? Are we together? Is it true from what we have talked about?
Yeah, it's
Boniface, what is your view on this?
Hello.
Yes.
Yeah, for me, I know that you have to check that retinopathy, but the time, if it's for 4 to 6 weeks, I don't know, but the screening is very important for those neonates. Yeah. It's what I know.
Okay.
It's very important, the screening of skin. But I don't know the master the exactly the time. Yeah.
Yeah, to make it clear, I think we've talked about this in the presentation. Screening is good, and you remember at the birth, the child is not seeing. So knowing that he's capable to see or not, it's not really feasible. This is why you give an appointment between 4 to 6 weeks so that the child will be brought to the health facility and confirm if he's seeing or not. So this is correct. Option B, newborn infants requiring oxygen therapy should have SpO2, which is SpO2 target, which is between 88% and 95%. Is it true?
Yes.
This is the target for, is it yes? This is for newborn.
No. This is not
for
yes.
all newborn.
No, this is first.
This
question is the first.
What is the light one? What is the light option here? This target is for who? The target of between 88% and 95% is for who?
They said it is for neonates, but they didn't specify.
Premature ones. Is it clear? Are we together?
Yes, we are.
Then option C, apunia. All of us, we understand what is apunia.
Yes, we understand.
Okay, so how apunia will lead to bradycardia?
There will not be production of energy for heart contractility.
The heart will be weak to pump a lot.
Yes, is the opinion is also can be there because of the hemodynamic disturbance. Then in that case, yeah, that case if there is the disturbance. Sorry, I'm on a bus.
I see.
If there is,
you can tell your neighbors to hold a little bit, then you respond.
Yeah,
Trifoni, thank you for trying. You can write in the chat if you are in Trifoni. You can write, yeah,
yes,
because
let
of
me
that
write in the chat.
noisy environment.
Yes,
Someone
yes.
else, and you mute yourself. You mute, then you write in the chat. Thank you so much, Trifoni. You are giving good explanation. Someone else from the participant? Who can try again to explain why apnea will lead to bloody, and this will further decrease the oxygen delivery. Of course, all materials are, yeah. Thank you, Prof. Prof is reminding us to visit LRC, which is having free good materials, which could be a reference in our future. So, as you were saying, apnea will lead to the heart will not, you know, the myocardium to pump, it needs energy. The energy will be done by having enough oxygen, which will facilitate the cell respiration and allow the myocardium to pump a lot. So if the myocardium is not having enough energy, it will not giving us enough beats. And finally, if the beats are not enough, even the oxygen which will be spread in the body will be decreased because because there is a decrease of that heart rate. The heart rate is decreased. The cardiac, of course, the cardiac output will be decreased, and finally the oxygen will be very low at cellular level. Thank you, thank you. So from the stem of the question, if we are asked, which one of the following statements are incorrect regarding oxygen therapy in neonates? What is the real response from here?
B.
Thank you so much. This is the real one. Thank you. Next slide, please. Can we have next slide? The question is saying where pulse oximeter is not available, oxygen should be given to all neonates who have cyanosis or respiratory rate which is above 70 cycles per minute, or who are too sick to feed. Is it true or false? If we don't have a pulse oximeter in our remote area, it's like a guideline for us in the future. If we are having clinical signs, we will not say that we don't have a pulse oximeter to detect that a patient is hypoxemic. So we have to consider the clinical signs. What is your view? What is your view on the option A? Is it true or false?
True.
Pardon? True. It's true. In children living in high altitude, the normal oxygen saturation is lower than those living at sea level, and a level of SpO2 such as below or equal to 87 could be used as the threshold for giving oxygen. True or false?
False.
Why?
They should get oxygenation at 92.
92.
At 90.
Those who are living in high altitude.
Yes.
What is the, thank you for trying. What is the view of other participants from what we have presented?
B is true.
B is true, because remember, if you are living in high altitude, the need for oxygen is low. It means we consider giving oxygen for people who are living in high altitude when the SpO2 is 87% or below. Those who are living, what you are saying, it's for C, the one who tried to respond previously, I didn't catch what the name, but what you are saying is C, the option C. Those who are living in low altitude, when they reach to us, we consider their indication for oxygen therapy when they are at 80%. But for those who are living in high altitude, we decide to supplement oxygen when they reach at 87%. Thank you everyone for responding. So the D is asking, oxygen should always be given intermittently, such as every hour or two, and should not be administered continuously in order to conserve, I don't see the other one, but this is like judging. You see, other drugs, we can give them every 2 hours, others every 6 hours. So for oxygen, is it the same? We give hourly?
Interruption is bad.
Interruption is bad. The oxygen should be continuous. If there is an improvement, we de-escalate. But if there is no improvement, we can even escalate to the other level of oxygen therapy. I think this is the last. Thank you, Jackie, for responding. The D is false. Thank you so much, Prof. I think this is the last slide for questions.
Okay, so I think that has been a good session. We are toward the end. If we remember again our intended outcome, we were to diagnose, how to recognize hypoxemia, how to pose a diagnosis of hypoxemia, and the pathophysiology and clinical considerations of hypoxemia. So I think this has been discussed. I think for our members who have been on the club for a while on our team, with hypoxemia has become just peanuts, something very simple for you. The usage of pulse oximeter has become familiar. Oxygen supply, oxygen delivery devices and options. I think since the very first session, that's what we started with. Today we emphasize on the pediatric considerations. The nasal prom are mostly used in pediatrics because it doesn't keep their mouths free. They can eat, they can smile, they feel free with that. They are like baby are not like adults. When they feel like the mouth is closed with the mask, they try to remove the mask, and yet it is the one saving their life. So you will see that people will try to keep the nasal prom as much as they can, unless the baby is so hypoxic and need very high FiO2, then we go to mask and others. So prescriptions of oxygen therapy and apnea therapy, we've seen the options. When do we diagnose? How do we diagnose? When do we go on invasive management? And how do we escalate and de-escalate? So I think we've gone through the questions and answers. And with this, if there is no other pending question, this is the end of our session. I will pass the floor to Alana and the assist team.
Thank you. So everyone, as Professor Benguti recommended, please visit the Learning Resource Center for additional resources and recordings. You'll also access other materials there, including other exercises, videos, quizzes, and more. The link to that is in the chat. We also encourage you to join our WhatsApp group where you can ask questions between sessions, and I'll share the link in a moment there as well. So in terms of next steps, please join us for session 10 on October 27th, where we will be talking about obstetric considerations for oxygen and critical care. So please save that in your calendar. And there, that's it. Thank you so much for joining today. Have a great rest of the day.
Thank you.